Let's go ahead and get started. We actually have a lot to cover in the next 4 hours. We've got 13 different sections to go over, and they're laid out in a kind of a weird arrangement. They're in the way that the med study has them laid out in the syllabus, and so that's the order that I went in the lectures. So we do jump around a little bit, but we're going to start with talking about the urinalysis and equations that you need to know for the pediatric boards. Socrates once said that the unexamined life is not worth living. The nephrologist says the unexamined urine is not worth peeing. It is one of the oldest laboratory tests in all of medicine. For over 1,000 years, almost 2,000 years, people have been looking at urine to get an idea of what's going on with the kidney health. You know, before we had UpToDate and our iPhones that we could check information on, people had cards that had all the information about their urine on them. In the Middle Ages, doctors were actually called piss prophets. I'm not making that up. I couldn't make that up. You could check that. Because of all the things that you can tell about someone from what's going on in their urine. This is not psychiatry. This is not the kind of urine, I'm pissed, that we're talking about. It is the most useful test to ascertain what's going on in kidney disease. We sometimes call it the liquid kidney biopsy. It can tell you about blood. It can tell you about white cells. It can tell you about casts. It can tell you about bacteria, crystals. And we'll get back to a lot of these different things. I'm just introducing the urinalysis at the beginning here. What it actually looks for is hemoglobin. So you can find hemoglobinuria, eosinophils, looking for allergic interstitial nephritis, protein, although specifically it's not looking at protein, it's looking at albumin, and there are some times where they give you false positives and also false negatives, and we'll talk about that. Other diagnostic tests that you're required to know for your board exam: the Schwartz equation, how to estimate the glomerular filtration rate, the fractional excretion of sodium, and some of the indications for when a renal biopsy is indicated: unexplained acute renal failure, unexplained glomerulonephritis, acute rejection in a transplant patient, or any time that the diagnosis is unclear, you can do a biopsy. Let's talk a little bit about these specifically now. The urinalysis, the dipstick, looks for blood, but as I said, it's not looking for blood, it's looking for hemoglobin. So if you don't have blood under the microscope when it's dipping positive, think about hemoglobinuria or myoglobinuria. Those will often show up on the boards. They'll give you someone who dipstick has large blood but doesn't have red cells. Proteinuria, again, it measures albumin, so false positive with a high urinary pH or with a very concentrated urine. The glucose is actually a specific test for glucose oxidase. In the old days, you used to hear about urinary reducing substances. That was looking for both glucose and galactose. Those were the urinary reducing substances. And then the other thing that we get on a urinalysis is the urobilinogen, which is really not all that useful anymore. It used to be sort of a poor man's test for liver function because you could get at the bilirubin and what the bilirubin in the blood is doing by looking at the urine. The urobilinogen is what makes the urine look yellow, and I've listed in your handout and also here on the slide some other things that change your urine to different colors. So red or pink urine is not always hematuria. As I mentioned, myoglobin and hemoglobin. So porphyria is one. And then there are a bunch of medicines, and I'm not going to bore you by listing them all, but there are medicines and beets and blackberries, things that can change the urine pink or red. Orange or yellow urine from nitrofurantoin or phenytoin, dark brown or black urine from alkaptonuria, green or blue urine from the Pseudomonas, the blue diaper syndrome, and then finally white or milky if there's chyle in the urine, or in patients with nephrotic syndrome who are leaking a lot of cholesterol-binding protein. The equation, this says GFR, technically more accurate would be to say a clearance equation. If you want to calculate the clearance of really anything from the bloodstream, just remember this picture. It's the sun on top with the little boy peeing on the bottom. The equation is UV, that's the UV light, over P. And so it's the urine, and in this case creatinine, the urine concentration of creatinine times the volume of urine divided by the plasma concentration of creatinine, and that's how you calculate a creatinine clearance. If you do a 24-hour urine, this is the equation. You can do 24-hour clearances for anything. I did creatinine here because it's common. Serum creatinine is increased in renal insufficiency. If that's news for you, we've got a lot more work than 4 hours is going to allow. But an elevated serum creatinine is not only in renal insufficiency. There are also drugs that block the tubular secretion of creatinine. We think of creatinine as a good marker for kidney disease because it is freely filtered and neither secreted nor reabsorbed. That's not actually true. It is secreted a little bit, and there are drugs that will block the secretion. The classic ones are cimetidine and probenecid. And if you've blocked the secretion, the serum creatinine will go up just a little bit, but it doesn't mean that the GFR has changed. Those are some false positive rises in GFR. The other is increased muscle breakdown. If you're breaking down muscle faster than is normal, you will have an increased production of creatinine. We see that in rhabdomyolysis. Now, we see an increased creatinine in rhabdomyolysis because of the renal failure, but they also get a more elevated creatinine than they would normally get for the degree of renal failure because the muscles are producing more. The new Schwartz equation, I don't know what to tell you about this when it comes to taking your board exams because I don't know if they've updated the questions to the new Schwartz equation. This just came out about 3 years ago or so. The original Schwartz equation that George did, 25 years ago, has been replaced. We still use the height over serum creatinine. It's height in meters over serum creatinine. What's changed is the constant, and there used to be 4 or 5 different constants that we would use depending on if you were a baby or a teen, boy or girl. Pretty much now the standard constant is 0.41 to get a pretty good estimate of the GFR for kids between the age of 1 and 16. That came out of the C-KID study, which is a large cohort study following kids in the United States with chronic kidney disease. The last thing I'll say about GFR, things that give you a high BUN to creatinine ratio. The classic that we all remember is pre-renal or volume depletion. But there are some others that can trip you up. So increased protein intake or increased protein breakdown catabolism. You mostly remember GI bleeding can cause a high BUN to creatinine ratio, and then hemolysis is the other. Fractional excretion of sodium. I don't know that you'll be asked to calculate this, but the formula, if you are, is the urine over plasma sodium divided by the urine over plasma creatinine, and then we multiply that times 100. Now, I know you can use algebra and flip around that set, but that's the actual equation, urine to plasma sodium divided by urine to plasma creatinine. We'll get to this a little bit later in the lecture, but just to remind you, the FeNA goes low when the kidney is reabsorbing all of the sodium. So in a pre-renal state, when the kidney wants to conserve as much volume as it can, you'll drop that fractional excretion of sodium. So in pre-renal, or actually in early GN as well, which acts as a pre-renal because the tubules are not seeing much flow because of the glomerular injury. Now, with a true kidney injury, either ATN or parenchymal renal disease, the kidney has lost the ability to reabsorb all of that filtered sodium, so the fractional excretion of sodium actually increases. And so classically with renal disease, you get a FeNA above 3. These are generally used in acute kidney injury with decreased urine output. At least classically, that's how they were described. I know in practice a lot of people use them with normal urine output or with high urine output, but classically it was for oliguric acute renal failure to determine whether the patient was oliguric because of pre-renal or renal failure. While we're talking about fractional excretion, you can also calculate the fractional excretion of other things. We generally do sodium, but you can calculate the fractional excretion of bicarb if there's any bicarb in the urine. Usually there isn't. You can calculate the fractional excretion of phosphorus, although just to keep it interesting, nephrologists don't calculate the fractional excretion of phosphorus. We flip it around and we calculate 1 minus the fractional excretion of phosphorus, and we call it the tubular reabsorption of phosphorus. But you can do that because there are some syndromes where people either waste phosphorus or in RTA you want to see if they're dumping bicarbonate. To finish up diagnostic testing in nephrology, let's talk a little bit about imaging studies. Ultrasound is the most commonly used imaging study as a general study. The last section that I have here for the day, the last thing that we'll learn is the urology section. There are a bunch of slides about urologic problems. You'll hear me say over and over and over again, get an ultrasound, get an ultrasound, get an ultrasound. It is the standard test to look at the structure of the kidney and to look for obstruction. I've been in nephrology for about 15 years. I have never ordered an IVP, but there was one on my pediatric nephrology boards a couple years ago. Classically, you would look for stones or obstruction with an IVP. These days, I think most of that has been replaced by CAT scan, by CT, specifically helical CTs looking for stones. You can also look for masses and cysts with CT. MRI is okay for looking at masses, but we really use it to look for vascular flow for renal artery stenosis and MRA. We try to avoid giving the gadolinium in people with advanced kidney disease. And then finally, renal scans. We get the nuclear med docs involved to help look at both kidney blood flow as well as kidney function and to look for scarring within the kidney. And then finally, an angiogram for vascular injuries. All right, let's change gears and start talking about acid-base disorders. I did hear a couple of groans out in the audience, so I was expecting it. That was my pause for groans. I think these are not as hard as people, I think that they are. I think we remember back to our chemistry when we were pre-med students and we didn't like chemistry, and so we have this thing against acid-base problems. But really, what you're going to get on the pediatric board exams will be, I think, relatively straightforward if you work through some steps. This is the most important equation that you should try to keep in your mind when you're thinking about acid-base problems. You have, and I guess I can use my finger on the screen, look at that. You have bicarbonate plus hydrogen ions, and this is the acid over here, that through carbonic anhydrase can convert to H2CO3, which can then convert to H2O and CO2. And what that reminds you of is the balance between what the lung is doing in blowing off CO2 and what the kidney is doing with bicarbonate reabsorption and hydrogen excretion. And so the bicarbonate buffer equation reminds you that whatever your pH is really a balance between what your kidney is doing and what your lungs are doing. Now, normally our lungs blow off CO2. We exhale the CO2. And our kidneys do two jobs for us because, frankly, they're the more interesting organ. They both reabsorb bicarbonate and excrete hydrogen ions for us. They do that in the form, they get hydrogen, they excrete it, and it binds with ammonia to become ammonium, or NH4, which then comes out in our urine. Some nomenclature when you think about acid and base disorders. Anytime you have a low pH, that is an acidemia. And anytime you have a high pH, that is an alkalemia. Regardless of what processes are going on, if there is an alkalemia, you know that there is at least one alkalosis going on. If there is an acidemia, you know that there's at least one acidosis going on. I firmly believe that this equation, the Henderson-Hasselbalch equation, is the sole reason that we had to take chemistry as a pre-med requirement. And I'm not, they put it on your syllabus as this huge long thing. Really, you just need to jump to the bottom of that. I'm not going to go through pKa's and the log of this and that because I frankly don't remember chemistry either. But essentially what you need to remember is that the pH in your blood is an amalgamation of what your kidney is doing divided by what your lung is doing. And that's why changes in kidney with RTA or changes in lungs with respiratory problems lead to acidemia and alkalemia. The primary acid-base disorders, there are 4 of them. You could have a metabolic acidosis where your body has lost bicarbonate. You can have a metabolic alkalosis where your body is holding on to extra bicarbonate. You can have a respiratory acidosis where your body is holding on to too much CO2. You can have a respiratory alkalosis where your body has blown off too much CO2. And from that Henderson-Hasselbalch equation, if you blow off too much CO2, you can see that's going to change your pH. If you hold on to too much bicarb, that's going to change your pH. That's why that equation is so important. When you evaluate acid-base disorders, the first thing to do is to look at the pH and see which way the problem is going. If there is an alkalemia, then you know that the primary problem is likely an alkalosis. If there is an acidemia, the primary problem is likely an acidosis. The next step, and I know it's crazy for a nephrologist to say to look at the lungs first, but look at the CO2 next because it's faster. It's right there, right next to your pH. They put it right there on the slip because that'll give you an idea of whether it's a respiratory problem or not. If there is an acidemia going on and the CO2 is high, then that's a respiratory acidosis. If there's an acidemia going on and the CO2 is low, well, that's a metabolic acidosis with a respiratory compensation. After you've seen whether or not the lungs are holding on to CO2 or blowing off CO2, you then have to look at what the kidneys are doing, look at the bicarbonate, and see if there's appropriate compensation. And then always, always, always check the anion gap, because even if the serum bicarbonate is normal at 24, it doesn't mean that there's not an acidosis going on. You can have a serum bicarbonate of 24 but a very low chloride, and it looks like, oh, well, the kidneys are doing the right thing, but in fact there's a huge anion gap acidosis going on. If there's an anion gap acidosis and a metabolic alkalosis going on, those two can cancel each other out in terms of the bicarb, and the bicarb can be normal, but you'll still see the increase in anion gap. And then finally, if there is an increase in the anion gap, you check what's called the excess gap, or the delta-delta. And to keep this without getting too confusing, what you're really looking for is, for each increase in the gap, is there a concurrent decrease in the bicarbonate? So a normal gap, and we'll talk about this in one of the few next slides, but if your gap has gone up by 10, you expect the bicarbonate to be down by 10. That means that the entire acidosis can be explained by that change in gap. Let's go through this a little bit more slowly now. You check the pH. I said if there's an acidemia, you know there's an acidosis. If there's an alkalemia, you know there's an alkalosis. Look at the pH. If there's an acidosis and your bicarbonate is less than 40, then that's a metabolic acidosis, not a respiratory acidosis. If there's an acidosis and the bicarb is higher than 40, that means that it's a primary respiratory acidosis. I won't go through that with the alkalosis. It's the exact same. But I do want to spend a little bit of time talking about the compensation. With a metabolic acidosis, what should your PCO2 do? What should the appropriate compensation be? Well, the PCO2 should be about 1.5 times your bicarb plus 8. And so as an example, if you have a metabolic acidosis and your bicarbonate has dropped to 16, what should the PCO2 be in response to that? Well, 16 times 1.5 is 24, plus another 8 is 32. So you would expect, if your kidneys got your serum bicarbonate down to 16, that your lungs would hyperventilate you down to a PCO2 of 32. That would be the appropriate compensation for that metabolic acidosis. You would get a respiratory alkalosis to compensate. Now, with a metabolic alkalosis, when your bicarbonate is elevated, your PCO2 should be 0.9 times your bicarb plus 16. And then with the respiratory acidosis, the question is, how much does your pH change for changes in your CO2? And it depends if it's an acute change in your PCO2 or a chronic change in your PCO2. If you could hold your breath and get your PCO2 from 40 up to 60 acutely, you would have a pretty rapid change in your pH, because it actually takes a while for your kidney to compensate for that. And so acutely, for each 10 increase in your PCO2, your pH will drop by 0.08, almost 0.1. So you'd get almost down to a pH of 7.2 if you got your PCO2 up to 60. Now, chronically, the kidney is able to compensate for that, and so for those changes in PCO2, you get a much smaller change in pH. It's about 0.03 for each 10 in in PCO2. Respiratory alkalosis is the exact same way. If you hyperventilate down for every 10 change in your PCO2, acutely your pH will go up by 0.08. But if you chronically hyperventilate, the kidney will account for that and hold on to a little extra acid for you so that your pH doesn't go quite so high. And so the next step, as I said, is to determine if these have happened, if the appropriate compensation has happened, to look for, is this just a respiratory acidosis, or is this a respiratory acidosis with a compensatory metabolic alkalosis, or vice versa? I mentioned the anion gap. It's a bit of a misnomer to talk about an anion gap because there is actually no anion gap in your bloodstream. The blood doesn't have lightning in it. It's electroneutral. What we're talking about is an unmeasured anion. For each cation in your bloodstream, there is an anion there. The anion gap is just, it's not a measured anion. The most common cation that we measure in our serum is sodium. The most common anions are chloride and bicarbonate. The gap is the difference between the sodium and the chloride and bicarbonate, and normal is around 10 to 12. I don't think anyone here is from Europe. In Europe, they include potassium, which is, of course, another cation in our bloodstream, and so their normal anion gap is actually a little higher because they have a couple extra cations. But for that confuses people when they read European articles and they talk about a normal gap of 14, and you're like, well, that's not a normal gap. It's normal in Europe. That's the way they roll. If you have an increased gap acidosis, this is probably the most commonly remembered mnemonic in pediatric nephrology, the mud piles. Methanol, uremia can cause an increased gas metabolic acidosis. Diabetic ketoacidosis, propylene glycol, isopropyl, isoniazid, or inborn errors. The I has to share with a lot of diseases. Lactic acidosis, the E is for ethanol or ethylene glycol, and S for salicylates. What you may not remember is the normal gap metabolic acidosis. The mnemonic that I always like to teach is hard up. H is for hyperalimentation. If you give too much TPN that has a lot of chloride in it, you can get a metabolic alkalosis. Acetazolamide, a carbonic anhydrase inhibitor. Renal tubular acidosis, the D is for diarrhea. Urinary diversion, we see this a lot in cancer institutions. If someone has a bladder cancer and has their bladder removed and we use a piece of ileum to replace it or to stretch their bladder, or if they've had obstruction and we use an ileum for an ileal conduit, what the gut, and I know you've already had GI, what the ileum normally does is it sees acidic contents coming out of the stomach and it secretes bicarb to neutralize it. That's what gut is supposed to do. Well, if you take a piece of ileum and use it as a ureter or use it as a bladder, it doesn't know that it's no longer a piece of bowel. It sees the acidic urine coming down and it secretes bicarb, and so you dump bicarb into the urine and you end up getting a non-gap metabolic alkalosis. And then finally a pancreatic fistula is the same. Now, I give you this mnemonic so that you will remember it all. In clinical practice, you really have ERD. Okay, you're really deciding between, is this an RTA or is this diarrhea? And clinically, that's the one that we have to deal with most of all. We get to RTAs a little later in the morning. I didn't want to overload you with too many acid-based stuff all at once, so I split up, and we're going to talk about RTAs when we talk about tubular function. If there is an elevated gap, I mentioned earlier, calculate the delta-delta to see if there's a secondary process going on. You can have both a metabolic acidosis and a metabolic alkalosis going on at the same time. You can actually have a non-gap acidosis and a gap acidosis and an alkalosis going on at the same time. So actually the most number of acid-based disturbances you can have going on in any one patient is 4. You can have all 3 metabolic problems and one of the 2 respiratory problems. You can't have respiratory alkalosis and acidosis at the same time, but you can have 4 different processes going on, and the way that you determine that is you see how much the gap has increased and has the bicarb decreased the same amount, or when you correct for the increased gap, is there still an acidosis going on? And so as I said earlier, if your bicarb is 15, so it's fallen by 9, if it's an increased gap acidosis, you would expect the anion gap to be increased by 9. If the gap is increased by only 4, then in addition to an increased anion gap acidosis, there is also a non-gap acidosis going on. All right, and then finally, you generate a differential diagnosis. The differential diagnosis, first of all, clinically, what does metabolic acidosis look like? Well, below a pH of 7.2, the body doesn't handle it very well. You get impaired cardiac contractility with arrhythmias. You can get impaired vasomotor tone, pulmonary vasoconstriction, hyperventilation as they compensate for that decrease in pH. Chronically, metabolic alkalosis just looks like failure to thrive. The kids don't grow well with a chronic alkalosis. I already went through this differential, so I leave it here, but I'm not going to go through it again. Metabolic alkalosis, volume depletion is your differential diagnosis. Hypokalemia, so they get muscle weakness or arrhythmias. Diffuse paresthesias. The most common cause of a metabolic alkalosis is volume contraction. It is true when you talk about a contraction alkalosis. What happens is the mechanism of that is as your body gets volume depleted, your kidney has to decide whether or not it's going to reabsorb sodium, potassium, or hydrogen. And there are sodium-potassium exchangers and there are sodium-hydrogen exchangers. And as you get volume depleted, your kidney realizes that volume is the most important thing, and so it starts holding on to every molecule of sodium that comes through the distal tubule. But again, you can't pee out lightning either. There has to be an electroneutral. So for every sodium it reabsorbs, it has to get rid of something that's positively charged, and it's either hydrogen or potassium. And so with volume contraction, you start holding on to sodium and dumping potassium and dumping hydrogen. That's why you get a contraction alkalosis. The classic for that is pyloric stenosis. And the medical students always think that people come in with pyloric stenosis, and the reason that they're hypokalemic and have a metabolic alkalosis is because they're throwing up stomach acid and they're losing all this acid by throwing up. That may be true, but mostly what they're throwing up is water, is volume, and they're losing so much volume that the kidney compensates for that by holding on to every single sodium molecule that comes its way. And so the kidney is responsible for dumping the potassium and dumping hydrogen so that it can hold on to that volume. And that's the classic triad of pyloric stenosis. Look, you get a bonus GI section in here. But they come in with, hypokalemic metabolic alkalosis and volume depletion, and that's it. The other chloride-responsive normal gap acidoses, gastric losses, pyloric stenosis, diuretics, a chloride-losing diarrhea. It's mostly GI stuff. They're losing the chloride or volume through their GI tract. Chloride-deficient formula, cystic fibrosis, and post-hypercapnic. Again, the kidney has responded to hypercapnia by losing chloride as a response, and so now you fix the hypercapnia, you've got to replace that chloride. Those are easy to treat. You just give them normal saline, and the acidosis, or the alkalosis will respond. The ones that are chloride resistant are a little bit trickier because there are some that present with hypertension. So you've got a metabolic alkalosis with hypertension, and those are adrenal adenomas. Sorry, I've got that pointer there. Adrenal adenomas or hyperplasias, glucocorticoid remedial aldosteronism, renovascular disease, and either the 17-alpha or 11-beta hydroxylase deficiencies. And then there are some inherited hypertension like Little syndrome. I don't think that'll be on your boards, but just for completeness sake, the true licorice also will present this way. I don't think in America we eat much in the way of true licorice. I love Twizzlers, but that's not the licorice they're talking about the black licorice. And then there are those that present with normal or even low blood pressure, which are the inherited Gilman syndrome, Bartter syndrome, the tubular dysfunctions, and finally, too much base administration. Respiratory acidosis, increased PCO2. We see that with CNS depression, patients who have a decreased respiratory drive. Disorders of the spinal cord or of the neuromuscular junction, their respiratory muscles are not working well. Finally, pulmonary disease, they're just not able to exchange air, they're not ventilating well. And then finally, upper airway disorders, they just can't exchange gas because of an upper airway disorder. Decreased PCO2 is more rare. If you have tissue hypoxemia, normally what our respiratory drive comes from, and I'm not a pulmonologist, but the respiratory drive comes from your PCO2. But if you get hypoxic, that will override your respiratory drive, and so you'll start hyperventilating in order to get more oxygen into your bloodstream. And so with carbon monoxide poisoning, when you don't have enough oxygen around, you'll hyperventilate in response to that. Lung receptor stimulation, if something you're stimulating your lung receptors, you'll breathe more. Central stimulation, I had a patient with a brain tumor who had central stimulation of it, and he was chronically had a respiratory alkalosis, was breathing. It was overbreathing. It was very difficult to control. Walked around with a pH in the 7.6 range. Mechanical ventilation is probably the most common cause of a respiratory alkalosis. It's a iatrogenic problem. We put a kid on a vent and we overbreathe the vent. And then finally, hyperammonemia. I do have some cases to keep you guys awake. A 16-year-old, and they're all in your handouts. These are the most important ones in the handout because the numbers won't be on the screen when you're looking. But a 16-year-old teen with an unknown past medical history is brought to the emergency room after friends found her unresponsive at a party. Her pH is 7.16, so she has an acidemia. So the primary problem is going to be a acidosis. You next look at the PCO2, which is 60, so this is a respiratory acidosis. You then look, and what should the kidney be doing? It should be helping us out with a metabolic wait a minute, the kidney's not helping us out. She also has a metabolic acidosis. Okay, so I'm not going to walk through all of them like this, I promise. That was the first one. We were getting into it slow. So are you guys ready with your audience response clickers? All right. All right. So, yeah, most of you got this one. This is a respiratory acidosis and an independent metabolic acidosis. You don't have a compensatory metabolic acidosis in response to a respiratory acidosis. But again, you had a high PCO2 and a low serum bicarbonate, so that's two different processes going on. All right, I'm not going to walk you through this. A 3-year-old girl with severe gastroenteritis comes to the hospital for hydration, noted to have a high bicarbonate the next day. ABG is ordered. You have the numbers in your syllabus. So this acid-base disturbance is, let you think about it for a second, and then we'll go to the next slide. All right. Only 9 of you answered. I'm just saying. Um, we should do some calisthenics or something. I only saw 9 of the 200 clickers got used there. But yeah, this is a metabolic alkalosis with a secondary respiratory acidosis. 7-year-old boy post-chemotherapy for sarcoma comes in for a routine clinic visit. Because he's got these abnormal blood chemistries with a bicarbonate of 16, an ABG is performed, and this is what they show. The acid-base disturbance is pure metabolic acidosis, respiratory alkalosis with a secondary metabolic acidosis with an independent respiratory acidosis, or metabolic acidosis with a secondary respiratory alkalosis. Looks like we had 66 people answer, which as a percentage of 200 is still down, but it's like a 400% increase from the question before. So we're doing well here. And yeah, most of you got it correct that this is a metabolic acidosis with a secondary respiratory alkalosis. Again, on the board exams, they're not going to try to trick you with these questions. I mentioned those multiple acidemias going on at the same time. You're probably going to get a single respiratory problem with a single metabolic problem, and figuring out which is primary and which is compensatory is really all you're going to need to do. A 7-year-old boy post-chemotherapy for sarcoma presents for routine. Gosh, this sounds familiar. Okay, it's the same question. Now you need to look at the urine studies. Let's talk about what's the underlying cause of his anion gap. And studies suggest that the cause of his acidemia is kind of a split around. Yeah, this is RTA. If you look at the numbers, they had a positive anion gap. All right, before we leave acid-base, I want to talk about osmolar gap because I'm board certified in medicine, pediatrics, nephrology, and pedinephrology, and I have yet to take a board exam that did not include someone with an increased osmolar gap. They love to ask these kinds of questions. Remember that you can measure the osms in the blood just by sending down a serum osm level. And you can calculate what you think the osmolarity should be by looking at what are the osmotically active things in the blood. Mostly it's sodium, so 2 times sodium, plus the BUN over 2.8, plus the glucose over 18. And the reason that you're dividing by 2.8 and 18 is because we in the United States report BUN and glucose as milligrams per deciliter, but milliosms are, we need to get to milliosms per liter. So the molecular weight of nitrogen is 14. There are 2 nitrogen molecules in BUN, so that's 28. But you need to get from deciliters to liters, so it's 2.8. Glucose, the molecular weight is 180. That's why you're dividing by 18. And normally, what you measure in the serum and what you calculate should be about the same. It should be less than 10. If you have a high osmolar gap, again, there is no such thing as an osmolar gap. The osms are all there. The question is, they're just unmeasured osms. And so if there's a high osmolar gap, then there are a lot of unmeasured osmoles there. Think about it, what they'll give you is an intoxicated patient with a high anion gap acidosis, and they'll put in there that he's got a, they'll give you the numbers and they'll tell you what his measured osmolarity is. You can calculate what the osmolarities are by calculation. If he has a high osmolar gap, think about the alcohol intoxications, ethanol, ethylene glycol, methanol. Again, it's been on every board exam that I've taken. They love to ask about that. We will get to the RTAs in a few minutes, but I couldn't talk about acid-base disorders without at least bringing up RTAs. For the board exam, there are really only the first two that you need to be able to distinguish between, the distal RTA and the proximal RTA. The distal RTA is a problem with acid secretion. If you remember at the beginning of this, I told you that the kidney was responsible for two things. One was for secreting hydrogen ions in the form of ammonium, and that's the problem in distal RTA. The kidney is unable to excrete those hydrogen ions. The other thing that the kidney does that has an acid-base role is it reabsorbs filtered bicarbonate, and that's what's broken in a proximal RTA. So in a proximal RTA, we are reabsorbing bicarbonate proximally, and if we don't reabsorb that appropriately, then we're dumping bicarbonate in our urine, but we don't have any problem making an acidic urine. That happens distally. And so a proximal RTA, you can still have a low urinary pH. In a distal RTA, the urinary pH is always high because you can't acidify your urine. The other thing I'll say is that last column about the fractional excretion of bicarb. In a proximal RTA, you have a high fractional excretion of bicarbonate. In a distal RTA, you don't have any problem reabsorbing bicarb. It's just getting rid of acid. 3 is a combined proximal distal. 4 is hyperkalemic RTA. And 5 is with renal failure. Again, I don't think you'll be asked about those on the boards, but I include them here for completeness sake. A 5-year-old boy with failure to thrive in acute diarrhea for 2 days has the following labs. pH is 7.34 with a PCO2 of 34, and his bicarb is 16. Urine pH is 5.5 with a very low urine sodium. The most likely diagnosis is RTA, uremia, diarrhea, or post-hypercapnic. Let's see if we can beat 66. 66 again. All right, yeah, this is diarrhea. This kid is volume depleted from diarrhea, has a very low urinary sodium, all right. That's all I'm going to say about acid-base disorders for now, although for those of you who are confused, I promise we'll get back to RTAs later. For those of you who want to put it behind you, I'm sorry, we're going to get back to RTAs later. Let's talk about glomerular diseases for the next, probably until the break or so. Specifically hematuria and glomerulonephritis, and then we'll talk about the glomerular diseases that cause nephrotic syndrome. Hematuria, I mentioned early on in the lecture, too many red blood cells in the urine, generally considered greater than 5 red blood cells per high-powered field. You can have so much blood in the urine that it's macroscopic, it's actually changing the color of the urine. I am not a pathologist, but you need to remember a little bit about the structure of the kidney in order to remember how these glomerular diseases work. You have an afferent and an efferent arteriole that bring blood into and out of the glomerulus, and then within the glomerulus you have these mesangial stalks, and within each stalk you have the capillary loops here where the filtration of urine occurs. If you get a biopsy done just right, you can sometimes catch both the afferent and efferent arteriole coming in. You see the nice open capillary loops here. You don't see much but maybe 2 or 3 mesangial cells in each of these stalks. That's a pretty normal looking glomerulus. And then on the ultrastructural level, if you were to blow this up with an electron microscope, what you see is the endothelial cell, and you don't see much of the endothelial cell, but there are the fenestrations within the lining of the endothelial cell, and then the really cool cell of the kidney is the glomerular epithelial cell. It's so specialized we don't even call it an epithelial cell, we call it a podocyte, and it's the one that has those interdigitated foot processes that has slits within those where the filtration of urine occurs. And then between the endothelial cell and the epithelial cell is your basement membrane. And there's actually only one basement membrane per glomerulus. It is continuous throughout the entire glomerulus. And it starts on one side and it runs all the way through and around. And that's where you get deposits in a lot of these diseases we're going to talk about. And I said we'll review these. This is what a normal glomerulus looks like. As I said, you often don't see much of the endothelial cell, but it's real easy to tell where the epithelial surface is because you see the interdigitated foot processes. And so this up here would be a blood space because here are the epithelial cells on this side. This is another blood space with epithelial cells here. And so this cell here is a mesangial cell on the outside. Blood is here, urine gets filtered out here. There are lots of places that you can get blood in your urine from. And in fact, it's probably more common to have blood in your urine not from the glomerulus than to have blood in your urine from the glomerulus. And so down in the bladder, down at the urethra, in the ureter, all of those can have problems, and we'll talk about those in the urology sections later on. What we're going to talk about for the next few minutes is glomerular bleeding, and I drew this because of copyright issues, and I didn't draw it very well, but we're talking about blood that gets sneaked out through. You see my little epithelial cells, the little bumps there? Anyhow. All right. And so you start off with a dipstick that's positive for blood. I will harp on you again that not everything that dipstick's positive is in fact hematuria. If you have fewer than 5 red cells, remember that what you're testing for is heme-containing proteins, hemoglobin. So hemoglobinuria or myoglobinuria, think about hemolysis, get a plasma haptoglobin, get a CK, see if they have rhabdo. If, in fact, they do have more than 5 red cells per high-powered field, by definition, that's hematuria. If they have red blood cell casts in the urine as well, you know it's glomerular bleeding, and I'll talk about that in a minute. But even without red blood cell casts in the urine, you can look at the red blood cell morphology, and if it's dysmorphic, if the red cells are distorted, that gives you an idea that the blood is coming from the glomerulus. And blood from the glomerulus is called glomerulonephritis because we can't just call it glomerular bleeding. We have to come up with a fancy name. And the clinical features of all of the GNs are hematuria, as I said, with or without red cell casts. They will often present with hypertension, with renal failure, oliguria, volume overload. And most of the conditions that present with nephritis will also have proteinuria. If there's inflammation within the glomerulus that's letting blood leak out, you also are leaking protein out. But we'll talk about nephrotic syndrome a little bit later on. I mentioned that a red blood cell cast is pathognomonic for glomerular bleeding. Anyone here ever made a candle or a wrought iron fence or a plaster cast of anything? If the answer to that is yes, then you understand why a red cell cast is pathognomonic for glomerular bleeding. The way a red cell cast is made is if you have enough blood within the tubules of the kidney, they will harden with the normal protein. We all have a little bit of protein in our urine. It's called Tam-Horsfall protein. And with enough red blood cells in the urine, they will make a literal cast of the inside of that tubule, and then that entire thing will break through, come through the collecting duct, down through the ureter into the urine. And if you see that, you know that at the level of the renal tubules, there was already blood in the urine. Well, there's only one place upstream of that where the blood can be coming from, and that's the glomerulus, and it's why a red cell cast is pathognomonic for glomerular bleeding. This is not from the bladder. This is not from a stone that's scratching the ureters. This is glomerular bleeding. When you have glomerulonephritis, there are a number of ways to think about your differential diagnosis. In adult medicine, we often talk about, is this a renal-limited disorder or is this a systemic disorder? In pediatrics, I would recommend that the easiest way to limit your differential is to look at the complement levels. I haven't seen a board exam with glomerulonephritis where they don't tell you that the complements are either normal or not normal. The reason is because you can almost cut your differential in half by looking at the complements. There are some classically decreased complement GNs like post-infectious, MPGN lupus, and there are some classic normal complement GNs like HUSIJ. We'll talk about all of these, I promise. First, let's remind you about the complement cascade. I'm not an immunologist. I assume you had that earlier in the week. But classically, when we think about how our body responds to a foreign object, you have an antigen that comes in. There are antibodies that recognize that as a foreign object, and the antibodies will clump and cross-react, and that antibody-antigen complex will then activate complement. Complement comes around, sees these complexes, and starts the process. Alternatively, the foreign object itself can activate complement independent of the antibodies, and so the alternative pathway is antibody-independent. And all you have to remember from the nephrology standpoint is that classically, C4 and C3 are involved in that process. And of course, the 5, 6, 7, 8 membrane attack complex is what gets us all the inflammation. But in the classic pathway, both C3 and C4 are used up, and so you get decreased C3 and C4. In the alternative pathway, C3 is activating C3 itself, and so only C3 is low. And so there are some GNs where it's both C3 and C4 are low, and some GNs where only C3 is low, and some GNs where the complements are normal, and those can give you clues as to what the condition is. Now, the hypocomplementemic GNs that show up on the pediatric board exams are post-infectious GN, membranoproliferative GN, and systemic lupus. There are others, but less common when it comes to both presentation clinically and also on board exams. Post-infectious GN is the most common acute GN that you're going to see. It is the majority of GNs in children. It's a peak age of between 2 and 15 years old when kids are getting a lot of strep throat infections. It's usually sporadic, although if you have a particularly toxic strain of strep that goes through a community, you can also get epidemics of post-infectious GN. In the winter and spring, we see it with pharyngitis. Kids get strep throat, and then a few weeks later we'll come down with GN. This time of year, when kids are out digging in the dirt, they get impetigo, and it's a skin-related infection. As I mentioned, it's usually a beta hemolytic strep that causes the post-infectious GN, but it's not only beta hemolytic strep, which is why I introduce it as post-infectious and not post-streptococcal GN. About 20% of the kids in the United States these days are chronic carriers of beta strep, and so the ASO titer clinically is actually not all that helpful anymore because 1 in 5 kids is going to have a high titer just because they're a chronic carrier. It is extraordinarily helpful, however, on board exams. They'll give you a high ASO titer, and they're trying to steer you towards post-strep GN. Treating strep throat will not prevent the GN. Everybody remember why we treat beta strep? Rheumatic fever, yeah, you had cardiology earlier this week. So you can prevent rheumatic fever and rheumatic heart disease by treating the GN. You can't prevent, you can't prevent the GN. And the reason is because of the pathogenesis of post-infectious GN. There are particular strains of strep that have particular antigens on them. And when your body starts making antibodies against those antibodies will get trapped within the glomerulus. There's something about the shape of those antibodies that get trapped in the basement membrane. They get trapped in the subepithelial surface of the basement membrane. And so if you look at this basement membrane, you get a nice thin basement membrane, and all of a sudden you get this huge, lumpy, bumpy subepithelial deposit. Here's another electron-dense deposit. Again, I don't think they're going to give you electron micrographs on your pediatric board exam, but just to remember that you're getting these deposits that's leading to glomerular disease. What happens is it takes about a week or two. You get the strep throat, your body starts making antibodies against the strep throat. It takes a week or so for those antibodies to build up, and then it takes a few days for those antibodies to get caught in your basement membrane, and then it takes a few days for that antibody that's in the basement membrane to activate complement. And so it's about a week or two from when you get a sore throat to when you come down with your GN. If it's a skin infection, it actually takes even longer because without a mucous membrane involved, it takes a little longer for your body to develop the immune response. Clinically, the GN presents with an abrupt onset of hematuria, and classically, it's described as Coca-Cola colored. Down here in Texas, we call it iced tea colored. I actually had an Asian family tell me that the urine looked like soy sauce, so it's, you know, pick your culture and go with it. They have generalized edema, and then clinically hypertension, pulmonary edema, and they can actually have seizures from this. On urinalysis, they have hematuria. Proteinuria is very common with post-infectious GN, usually not nephrotic range proteinuria, but they will have some proteinuria. Lots of red cells and often red cell casts on a UA. Renal function is decreased, so again, a review for you, high BUN and creatinine. And then ASO titers are elevated. Complements are usually profoundly low, at least C3 is low, C4 typically not low. And then the clinical course of this, the clinical nephritis is usually better within a few weeks. And so most people recover from this, and they're not peeing blood, their hypertension is getting better, all within a few weeks. The complements actually take a couple of months to get back to normal. The proteinuria can last up to 6 months, and the hematuria can last even longer than that. As I mentioned, antibiotics will not prevent the GN, so treatment of acute post-infectious GN is supportive therapy, sodium and fluid restriction if they have edema and volume overload. If they're hypertensive, we can use diuretics to help them get rid of some of that volume or other antihypertensives. And as I said, most patients will recover completely from this. There is some residual renal impairment depending on how bad they present with, and there is about a 0.5% mortality. Less than 1% of people with ESRD have ESRD because of post-infectious GN. The reason I told you about when the complements come back to normal is because the other chronic low complement GN is membranoproliferative GN, and this is another one of these pediatric disorders that they like to ask about on board exams. Clinically, it presents a lot like post-infectious GN. You say, oh, this looks like post-infectious GN, but 2 months later, their complements are still low, and they still have hematuria and proteinuria. And 2 months after that, their complements are still low, and they have hematuria and proteinuria. And MPGN. There are 3 types. I don't think you'll be asked about the different types of MPGN. Now, when you think of MPGN for the med-ped docs in the room, you should be thinking about hepatitis C because that's the most common in adults cause of MPGN. That's not what we're talking about here. In kids, they get an idiopathic MPGN that is an autoimmune complement activating process. They are continually activating their complement. They have chronic low complements. On biopsy, as the name implies, they have a lot of proliferation. It's mostly a mesangial proliferation, and the mesangial cells proliferate so much that they actually grow into the basement membrane and split it open. And so classically, you get what's called the tram tracking of the basement membrane. The natural history of primary MPGN, we don't know a whole lot about it because it's not very common. Depends if you're a glass half full or a glass half empty kind of person. If you're a glass half full, you would say that there's a 50% renal survival at 10 years. If you're a glass half empty, you would say there's a 50% renal survival at 10 years. You know, works the other way. That means half the kids are on dialysis at 10 years. It's much slower than in adults. Adults who have hepatitis C-related MPGN, most of them are on dialysis within a few years of developing their hep C MPGN. The things that portend a worse prognosis are type 2 MPGN, which is a more dense deposit within the basement membrane, and severe nephrotic syndrome, treated with years of glucocorticoids. All right, nephrologists can't talk for an hour without mentioning lupus, and I'm just under an hour, so let me bring up lupus. It's interesting, though, because it's not actually a renal disease. It's a rheumatologic disease. There are 11 major criteria for lupus. Renal disease is one of the 11 major criteria. And unlike in adults, who usually present with more of the rheumatologic findings, joints, arthritis, etc., in kids, renal disease is usually the presenting finding in lupus. About 2/3 of pediatric lupus is diagnosed in a nephrologist's office, not from the rheumatologic findings. Laboratory, they have decreased C3 and C4. They have a very active urinary sediment with lots of red cells, lots of casts. The treatment is for lupus nephritis is still high-dose glucocorticoids and cytotoxic agents, either monthly IV Cytoxan, or there is now a protocol where you can give oral MMF. The prognosis is still somewhat guarded because of the long-term nature of the therapy that we have to give. Let's switch gears and talk about the normal complement GNs, HUS, IgA nephropathy, and Henoch-Schönlein purpura. There's also Alport syndrome, which I include here as a GN, although we're actually going to talk about it as one of the hereditary glomerulopathies. But hemolytic uremic syndrome is one of these great diseases that if you remember the name, you got 2 out of the 3 of the triad. The triad is hemolysis, so microangiopathic hemolytic anemia, kidney failure, that's the uremic part, and then all you have to remember is the low platelet count, and you've got the triad. Unfortunately, it's not that simple. You have to remember a little bit more about it. This is a disease that's been known about since the 1950s, but our understanding of it changed entirely in the 1980s when we discovered the association of E. coli 0157H7 with diarrheal HUS. It's not a very common condition, only about 2 per 100,000 per year, but it is more common in pediatrics, about 3 times around. It's about 6 per 100,000 per year in kids under the age of 5. We are just now leaving HUS season. There is a seasonal fluctuation of HUS, and it is a summer disease. It's weird. I haven't seen much of it. I've been practicing nephrology in Texas since '99, and we don't see a lot of HUS here in Texas. I did my residency up in Rochester, New York, and we saw a lot of HUS, and I don't know why we don't see it as much down here. Maybe we like to burn our burgers a little bit more. I don't know. It is classically referred to as diarrhea-positive HUS. There is a Shiga toxin that's produced by this E. coli 0157H7, and the classic presentation is an acute prodromal gastroenteritis with then a sudden onset of hemolytic anemia, thrombocytopenia, and renal failure. The diarrhea is usually hemorrhagic. About 2/3 to 3/4 of the diarrhea is hemorrhagic, and the renal failure is within a couple of weeks of the diarrhea. They also have a lot of CNS abnormalities, and they'll throw that in on the board exams. Kid will be having seizures or will be somnolent, and that's another clue about HUS. It's not from the renal failure. It's because the Shiga toxin crosses the blood-brain barrier, and they get neurologic complications. It's not only E. coli. Obviously, if it's a Shiga toxin, Shigella can cause this. And there's also an atypical infectious HUS, which is caused by strep pneumonia. Now, that's not to be confused with atypical HUS, which is an inherited hereditary problem that has to do with complement deficiency. This is atypical infectious HUS. The transmission of E. coli 0157H7 is usually from undercooked ground beef, but beef gets a bad name. It can also be from turkey, from ham, from radishes or sprouts. Actually, the Taco Bell outbreak of 2006 was traced back to shredded iceberg lettuce at those Taco Bells. It had nothing to do with meat. You can get person-to-person transmission, and I'll just be careful where you swim. You can get it that way too. The incubation for the E. coli 0157H7 is about 3 or 4 days. Typically begins with crampy abdominal pains and diarrhea that becomes bloody within a few days. About half of the patients will have nausea and vomiting, and considering how sick they look with bloody diarrhea, nausea, and vomiting, not much in the way of fever. It's usually an afebrile disease. It's a pretty infectious bug. Between 1/3 and 2/3 of those who are exposed to the E. coli 0157H7 will develop the colitis. Fortunately, much fewer of them will develop HUS. It's only about 2 to 7%. The final thing I'll say about this E. coli is it's not detected in routine stool cultures. It has to be plated on a macaque auger, so you have to specifically ask the lab to look for it. If someone has E. coli 0157H7, the treatment is supportive. Don't treat with antibiotics. Actually, if you treat them with antibiotics, you can decrease their gastroenteritis. And in the studies that they did, and they've done randomized controlled trials of this, the people who got antibiotics improved their GI symptoms on average about 20 hours sooner. So you could shorten the length of their illness by about 20 hours. But what you also did was almost triple their risk of developing HUS. And so that's why we don't treat with antibiotics, because the trade-off of 20 hours of less diarrhea for tripling your risk of HUS. It is a pretty bad disease. If they get HUS, about half of them will require dialysis for their HUS. And unlike that atypical HUS, which was the inherited factor deficiency, with typical HUS, we don't generally recommend plasma exchange. There's nothing that we can exchange with. The prognosis of HUS is actually pretty good. About 90% will recover, but there is about a 3 to 5% mortality with acute HUS. And if you do the math here, 90% recover, 3 to 5% die. That's another about 5% who are left chronically on dialysis from HUS. The things that portend a worse prognosis are kids who completely shut down their kidneys, so anuria. The more severe the gastrointestinal prodrome, and kids under the age of 2 often don't tolerate this as well either. Let's talk about IgA nephropathy. It is the most common primary chronic glomerulopathy worldwide. That's kind of a mouthful, but you have to say all of those words in order for it to be true. It's not the most common primary glomerulopathy worldwide. We've already talked about that. The most common primary glomerulopathy worldwide is probably post-infectious GN, and it's not the most common chronic glomerulopathy worldwide either. That's unfortunately now diabetes, but that's not a primary glomerulopathy. But if you include all the words, primary, chronic, and glomerulopathy, now IgA comes there. It's a really neat disorder. I actually did a Cochrane review on the treatment of IgA nephropathy back when I was a renal fellow. It's not all that common in the United States, but if you start heading eastward, the farther east you go, the more common it is. So in the United States, it's only about 2 to 10% of GNs. In Europe, it's about 15 to 20%. It's about 30% when you get to the Middle East. And when you get to China and Japan and the Far East, which is also the Near West, if you think about it. But if you get to the Far East, it's about 40% of all GNs in Asia. Not really understood why it's so much more common in Asia than it is in anywhere else in the rest of the world. This was first diagnosed back in 1968, which incidentally, or perhaps not incidentally, is the year that we figured out how to do immunofluorescent staining. And we initially thought that it was a benign entity because all these people had microscopic hematuria that was intermittent. And now we can do these immunofluorescent staining, and oh, look, they have IgA that's deposited in their mesangium. We now know that if you follow the people long enough, anywhere from a third to a half of them will develop ESRD. This is what it looks like if you look at an immunofluorescent stain. And this is the only immunofluorescent stain I'm going to show in the entire day. And I also included in your handout. What you'll notice here is that the glomeruli actually are not where this disease is. All of the staining is in the mesangium. The IgA is getting deposited within the mesangium of the kidney, but it slowly will build up and lead to mesangial scarring, which will eventually lead to renal failure. It is most commonly diagnosed in pediatrics, people in their second and third decade of life. It's more often in males than in females, and you'll notice this is a recurring theme when we talk about GNs. They often tend to be in boys more than girls. 80% will have macroscopic hematuria, and unlike post-infectious GN, which we said they had a sore throat, and then 2 weeks later they woke up peeing blood, this is considered synpharyngitic, i.e. they had a sore throat last night, and this morning they woke up peeing blood. So it's at the time of sore throat infection. Kind of makes sense. It's an IgA disease, which is the secretory immunoglobulin that we have in our throats. You get a sore throat, you get an infection that rubs up the IgA, and then you come down with blood. There have actually been some randomized controlled trials of looking at how to treat IgA nephropathy and whether or not you can do tonsillectomy. It doesn't work. It was a cool idea, but it doesn't work. We do treat with glucocorticoids as the mainstay of therapy. The long-term follow-up in Japan, again, we initially thought that this was a benign disease. At 5 years, only 5% of the people had renal failure. Even at 10 years, it was only 6% of the people. But if you follow people long enough, 20, 30 years after they were diagnosed with this illness, about a third of them are on dialysis. The things that portend a worse prognosis here, older onset. Now, this is not a pediatric older onset. This is age over 50 when you're diagnosed. And taking off my nephrology hat and putting on my epidemiologist hat, I suspect that this is not a true finding, but this is a lead time bias, that if you're over the age of 50 when you're diagnosed with IgA nephropathy, it's not that you're going to do worse because you're old, it's because you've probably had it for 30 years, you just didn't know it. Macroscopic hematuria, the more bouts of gross hematuria you have, the more likely you are going to progress. And those who have heavy proteinuria, generally more than 1 gram per day, is considered a bad prognostic sign. All right, Henoch-Schönlein purpura is a systemic vasculitis. And you probably talked about this earlier in the week too, HSP, yes, no, maybe. All right, well then from the nephrology standpoint, what I can tell you is that it is absolutely no different than IgA nephropathy. It's the same IgA molecule, it's deposited in the same place as IgA. The difference is that it's a systemic vasculitis and it gets deposited elsewhere too. It's in the skin, the joints, the GI tract. I have my obligatory picture of palpable purpura. In the interest of time, I won't have you come up here, but I promise if you could come up and feel these lesions, these are palpable purpuric lesions. And what I'll say at least about the nephrology aspect of HSP is that not everybody with HSP will have nephrology aspects. It's only about a third to a half of the patients with HSP who have the nephritis. And the cool thing is that if they're going to have nephritis, it happens early in the course of their HSP. It's about 95% of people with HSP nephritis will be diagnosed with their nephritis within the first 3 months of their HSP. So it's not uncommon for us to have a kid with HSP that we know has nephritis with HSP, but they don't have much in the way of skin findings, and then a year later they come down with a palpable rash, or they come in with GI bleeding. The opposite of that is uncommon. If they've had the skin disease, if they've had the rash, and they've had it for months and months and months and don't have any renal problems, chances are they're probably not ever going to have any renal problems. Now, the prognosis of HSP really depends, and specifically the nephritis in HSP, really depends on how they present, the risk for chronic renal disease. If they just have a little bit of mild hematuria or minimal proteinuria, fewer than 5% of those kids are going to progress to end-stage renal disease. If they have massive amounts of proteinuria, they're more likely, and if they have nephrotic range proteinuria, again, 40% of those kids. So if they come in with full-blown nephrotic syndrome, those are the kids that we worry about and treat with, again, usually alternate-day steroids for a couple of years. All right, those were the glomerular nephritis that we're going to talk about. Let's move on to section 4 and talk about proteinuria and nephrotic syndrome. Proteinuria is one of the more common findings on a urinalysis. It's up to about 3.5% of all urinalyses. It may be temporary, it may be benign, or it may be something that's non-progressive. At the same time, it may represent the only clinical finding of a serious underlying kidney problem. As I mentioned a few minutes ago when we were talking about red cell casts, all of us have a little bit of protein that comes out in our urine. It's usually less than about 4 milligrams per meter square per hour, or less than 100 milligrams per meter square in a day. See how I can do that math with multiplying by 25 and getting that? All right. It's greater during the daytime when we're up jostling our kidneys around, much less at night when we lie down and are not jostling our kidneys around. Anywhere from 5 to 15% of kids will have proteinuria at some point during childhood. Fortunately, much fewer of them will have persistent pathologic problems. In the old days, when we wanted to know how much protein somebody was making, we would give them a jug and we would have them collect 24 hours worth of their urine and bring it in, and we would measure how much protein was in there. That was a pain, particularly in pediatrics when kids aren't always potty trained. We would have to admit them and put a Foley catheter in to get a 24-hour urine. These days, you are much more likely to see a protein-creatinine ratio. The theory behind a protein-creatinine ratio is that if your serum creatinine is in steady state, and it doesn't matter if your creatinine is 0.4 or if it's 3, as long as your creatinine is 3 today and 3 tomorrow, all of the creatinine that your body makes in a day is excreted in that day. And so what we can do is we can normalize the amount of protein to the creatinine that comes out. And so for a 70-kilo adult, they make, you and I and kids and everyone, we make anywhere from about 13 up to maybe 18 milligrams per kilo of creatinine per day. So that's how much creatinine should be in a 24-hour sample. It's one of the ways we tell if a 24-hour sample is complete or not. But even without a 24-hour sample now, we get a spot urine, we check the protein, we check the creatinine, and that ratio should be less than 0.2. Again, the number I gave you there was for an adult, normal protein of less than 200 milligrams per day, normal creatinine of 1 gram per day, so the ratio is 0.2. That's true in pediatrics as well. A small child may only have 300 or 400 milligrams of creatinine in a day, but the amount of protein should still be less than 0.2 of that. And so a ratio of 0.2 is normal. Anything higher than 0.2 indicates that there is excess protein coming out in the urine. Nephrotic syndrome being a syndrome, it's defined as the clinical presentation of proteinuria severe enough to lead to hypoalbuminemia with subsequent edema and hypercholesterolemia. There is normally not only a size barrier, but also a charge barrier that prevents us from leaking negatively charged proteins out. You see the picture of the basement membrane there and the epithelial foot processes. And normally the negative charges here prevents protein from getting through. There's a problem there. People have dedicated their lives to getting really cool pictures of these podocytes, specifically the foot processes where the slit diaphragm is. This is where filtration of urine occurs, and it's a problem here often when you have nephrotic syndrome. The interdigitated foot processes, it's usually not the same foot process. It's the podocyte here and a podocyte here that interdigitate with each other. There are podocin and nephrin molecules that hold these tails out. And because they have these negatively charged ions out here, it bounces proteins back in. And so a problem in nephrotic syndrome generally occurs right here along those podocytes. Talking some numbers, usually you have more than a gram per meter square per day or a protein creatinine ratio greater than 2, usually more than 40 milligrams per meter square per hour. The hypoalbuminemia, usually less than 3. This is where you get to see how low your lab can go. I practice at one hospital where they say the albumin is less than 0.5. That's as low as they can measure. The other hospital across town is just less than 1. I did my residency. They measured down to 0.1. It's pretty scary when you see an albumin less than 0.1. There's just none there. Hypercholesterolemia, one of the proteins that they lose in nephrotic syndrome is cholesterol binding protein. And so without cholesterol binding protein around, you get very high triglyceride or cholesterol levels. And then classically, it presented with edema. And so if you read the textbooks, they would say that edema is part of the nephrotic syndrome. I will tell you clinically, there are a lot of kids who have all the full-blown nephrotic syndrome, but at least I can't tell that they have edema. I still say that that's nephrotic syndrome, although, again, as a syndrome, it's supposed to have all of the findings. It will often present with edema, though, usually facial edema, or sometimes it's in the belly. They get increased abdominal girth. These kids often look like they've got some allergy or something because their eyes are all puffy and swollen. And so someone says, oh, you have allergies here, take some steroids. That's the treatment for nephrotic syndrome, so it gets better. So eventually someone thinks to check the urine, and we say, aha, you have nephrotic syndrome. The etiology, the epidemiology rather, it's not a very common condition, only about 2 to 7 per 100,000 under the age of 16. But because it's a chronic condition throughout childhood that will relapse and remit and relapse and remit, the prevalence is much higher. It's about 15 per 100,000 or 1 in 6,000 kids. It's a disorder generally of young kids. 80% are less than 6 when we make the diagnosis of nephrotic syndrome. The median age for minimal change is about 2.5. FSGS is a little older because it's a common in teenagers. It's about 6 years old. Again, like with the other GNs I talked about, more common in boys at a young age. When you get into the teenage age, girls and boys have it equal. The causes of nephrotic syndrome that show up on the board exams and, frankly, that show up in the clinics as well. Minimal change is the most common. I didn't know what to put on this slide. It used to be listed as about 85% of all pediatric nephrotic syndrome. It's now probably closer to about 65%, and the reason for that is because over the last few decades, FSGS has become more common. And so FSGS, which I had at 10%, is now probably closer to about 25%. But just know, by far and away, minimal change and FSGS account for overall about 90% of all nephrotic syndrome in pediatrics. Membranoproliferative GN, which we already talked about, can present both with the nephritis. It can also present with nephrotic syndrome. And then finally, diffuse mesangial-proliferation can present with the nephrotic syndrome. In adults, again, I know this is a pediatric board review, but membranous nephropathy is the most common cause of nephrotic syndrome. Diabetes is a very common cause of the nephrotic syndrome. And then there are lots of other causes. IgA nephropathy, which we talked about as a glomerular disease that presents with hematuria, can also present with the nephrotic syndrome. Heavy metal intoxication, proliferative GNs, post-infectious GN, and lupus, I mentioned, can present with nephrotic syndrome. HIV and hepatitis B both have GNs that present with nephrotic syndrome. And then finally, in cancer institutions, patients with cancer will often present with nephrotic syndrome, either from myeloma, lymphoma, or solid tumors. Slide is included in your handout, goes through the different causes of nephrotic syndrome and where the lesions are on the kidney, We've talked about IgA nephropathy. Those are mesangial deposits. You see those in the mesangium. We talked about post-strep acute GN or PSA-GN or post-infectious GN. Those are the subepithelial deposits. We talked about lupus, and although I didn't mention them because I don't think you need to know them for the PD boards, the deposits in lupus nephritis are subendothelial. They're on the endothelial surface of the basement membrane. The membranous GN, as the name implies, are within the basement membrane. That's where the deposits are. And then finally, we won't spend a lot of time talking about it, but Goodpasture's disease, you get linear deposits within the basement membrane. And so again, a nice slide that shows for the different causes of nephrotic syndrome where you get the deposits. Minimal change disease, whether it's 65% or 85%, it is still the most common cause of nephrotic syndrome in childhood. It's sometimes called Nill's disease or lipoid nephrosis because they're losing a lot of cholesterol, so they have the hyperlipidemia. There are a lot of secondary causes of this, but in pediatrics, it's usually a primary problem. We diagnose it, as we diagnose any of these nephrotic syndromes, by biopsy. You can't tell what the cause of nephrotic syndrome is without a biopsy. We don't always do a biopsy. We'll often treat them without a biopsy, but if you want to know what the condition is, you have to get a biopsy. And as the name implies, there are minimal changes. So the light microscopy usually looks pretty normal. The immunofluorescence is negative. There's nothing that lights up there. And on electron microscopy, you get podocyte fusion. Now, that's the term that they use. It's probably not an appropriate term because you don't actually fuse your podocytes. What you lose is loss of the fenestrations. You lose the interdigitation of the foot process. And so this is what you see. And I think the more appropriate term that pathologists are using these days is effacement of the foot processes. So instead of seeing the nice interdigitated foot processes, you see effacement or just a flattening of those podocytes. In one of the prettiest pictures in, remember normal looked like this. You had those nice interdigitated foot processes. In one of the prettiest pictures in pediatric nephrology, maybe I'm just a sucker for scanning electron microscopy, but this is a normal-looking glomerular epithelial cell, and you can see, or maybe you can't for the way it's projected there, but the nice little feathery interdigitations between those epithelial cells, you can catch them most right in here and right in here and some over there. And so this is a normal-looking scanning electron microscope of a glomerular capillary with those podocytes. In nephrotic syndrome, they look like this, and I included that picture in your handout. There's just a loss of all of those feathery interdigitations. FSGS, the second most common cause of nephrotic syndrome in childhood. It's more common in older kids, it's more common in teenagers, it's more common in males, and it's more common in African Americans. That's a lot of things that it's more common in. You guys remember Sean Elliott? He was a basketball player. How many of us are from Texas? Most of us? Yeah, so he was a basketball player for the San Antonio Spurs. He was going to get traded to the Houston Rockets, and then the team doctor turned down the trade because he was sick. He didn't pass the physical. Well, what he had was FSGS. I'm not breaking any confidentiality here. He came out about this. But he had FSGS, and actually about a year after the trade fell through, he ended up developing end-stage renal disease and had to go on dialysis. He eventually got a kidney transplant and went back to the NBA and played professional basketball with a transplant. He was a wonderful role model for our patients who think that their life is over when they develop renal failure. The same can be said of Alonzo Mourning. I think he played for Miami, is that right? He played for the Heat. He was a center. He also had FSGS, developed ESRD, got a kidney transplant, and went back. And I actually think he wrote a book. And I'm not his publicist. I'm not trying to push it, but he probably ghost wrote it. I don't know that he wrote it, but he wrote his book about what it was like living with kidney disease and getting a transplant and going back into the NBA. FSGS, as the name implies, is a focal disease, and the focal means that it's not the entire kidney that's involved. It's just little focal areas of the kidney that's involved. It's segmental, and what segmental means is that even within the glomeruli that are affected, it's not the entire glomerulus that it's affected. It's just a small segment of the glomerulus. Some of the capillary loops are nice and opened. Others of them are scarred down. And glomerular sclerosis is just a fancy way of saying scarring. So these are people who are scarring their kidneys, not all of their kidneys, part of their kidneys and part of the glomeruli within those kidneys and part of the but in any case, it's a disease that often will progress. It's much less steroid sensitive than minimal change disease. The initial workup at my hospital, we're able to order what's called a pediatric renal profile. Unless you work at my hospital, you can't order that because they won't know what it is. But what you need to order is a Chem7, a calcium and phosphate mag. Those are sort of typical look at renal function type tests. We look at albumin, total protein, cholesterol, and triglycerides because, again, with nephrotic syndrome, you have hypercholesterolemia, and you want to look at those. You have hypoalbuminemia. You want to look at the albumin level. And then once you get those back, you'd kind of like to make sure that you don't have those problems because of liver disease. And so we add in an AST and a total bili as part of our pediatric renal profile. You probably want to get complement levels because, as I mentioned, a lot of those hypocomplementemic GNs can present with nephrotic syndrome. Hepatitis profiles, a CBC. You may or may not get a renal ultrasound to look at the structure of the kidneys. And then finally, you may need, as I mentioned, a kidney biopsy. Often we'll treat this without a biopsy. The treatment, non-pharmacologic, diet, salt restriction and fluid restriction, certainly if they have a lot of edema, get them as active as possible, out of bed, walking around, try to mobilize that fluid out of the interstitial spaces. Diuretics are rarely needed, but if they have significant peripheral edema, we can give them diuretics. The most common diuretic we'll give is Lasix, but remember, or maybe you don't remember, so I'll tell you, Lasix is protein bound. So when someone whose albumin is less than 0.5, Lasix isn't going to work unless they get some albumin as well, and that's where we use albumin in the nephrotic syndrome. We'll give them albumin and Lasix together to give the Lasix something to hold on to so that it will work. It also acts as a bit of an osmotic pull to pull some of that interstitial fluid back into circulation so that the diuretic can help them urinate it out. Blood pressure management in nephrotic syndrome is a bit of a challenge because half of you in the room are saying, okay, these patients have a lot of edema, they're very sodium avid, they're overloaded, they're probably hypertensive, and you guys would be right. The other half of you in the room are saying, now wait a minute, without albumin in the bloodstream, they've seeped all of that fluid out into their interstitium, and they may be volume depleted and they might be hypotensive. You guys are right too. And so patients with nephrotic syndrome, the blood pressure may be high, it may be low, you really have to follow it carefully. If you are going to treat the blood pressure, as I said, diuretics are usually the first agent of choice. You can use other agents as well. And then the mainstay of pharmacologic therapy for the nephrotic syndrome is glucocorticoids, regardless of the cause. That's generally what we'll treat with. All right. I told you we were going to talk about Alports. That's in this section, which is section 5, the hereditary glomerulopathies. So Alport syndrome is a glomerular disease, but it's inherited, so I didn't know where to put it, and I put it in here with the inherited disorders. The mode of inheritance is variable. Classically, it is an X-linked disease, and so it's generally a disease that we see in boys. It is a disease that we diagnose in pediatrics, but it's not a disease that generally causes kidney problems in pediatrics. What it causes in kids is the hearing disorder, but the boys who get it will invariably progress to ESRD. They usually do so in young adulthood, in their 20s, 30s. It is an abnormality of type 4 collagen. We have that collagen in the basement membrane. We also have it in the lens of our eyes and in the cochlea of our ears. And so the criteria for Alport syndrome include 3 out of the 4 of these: familial hematuria, so family history of renal disease, classic findings on biopsy, thickening and splitting of the basement membrane. Again, the collagen is not laid down normally, so the basement membrane doesn't look normal. They have characteristic ocular lesions, which for those of you who care is called lenticonus. You won't need to know that they have ocular problems, and so everyone that you diagnose with Alport should be sent to an ophthalmologist to screen for that. And then finally, they have sensorineural neural hearing loss. Now, the hearing loss is bilateral, and it's not present at birth. So these kids usually pass their newborn screening exam, but by the time they're in high school, about 85% of boys with Alports will have noticeable hearing loss. It is progressive. It is at frequencies that are involved in human speech, and so they will often need hearing aids. I say that that the diagnosis is 3 out of the 4. That is somewhat historical now because there are genetic tests that you can order for Alports these days. But still on board exams, those are the clinical findings. Thin basement membrane disease is the cause of benign familial hematuria. It's an autosomal dominant condition that is, as the name implies, a benign condition. If you have to diagnose it, you can diagnose it by biopsy, and you see, surprise, surprise, the basement membrane is thin. And again, I'm not a pathologist, but there are, how many angstroms thick are your basement membranes supposed to be? And in these families, they just have thinner basement membranes than you and I do. And with that thinner basement membrane, blood is able to sneak out. There's generally no family history of kidney disease, and no treatment is required for this. One of the things that we will always do when a kid gets referred for hematuria, if they don't have proteinuria, they don't have hypertension, they don't have renal problems other than microscopic hematuria, we'll bring mom or dad in, or actually mom and dad in if we can, and we'll look at their urine, because often we'll find that this is a family history. And if we're going to biopsy somebody, usually mom and dad would like themselves biopsied rather than kid biopsied. Denny's-Drash syndrome is one of the conditions that presents that increases your risk of renal cancers. And so the way that I saw this on my pediatric boards eons ago was they asked which of the following conditions does not increase risk of, and they listed a bunch of them, and this is one that does. I don't think they have those questions anymore, all of the following except, but they used to. Anyhow, Denny's-Drash is an XY gonadodysgenesis, so these are genetic boys, but they often present with ambiguous genitalia or looking phenotypically like girls. They develop nephrotic syndrome in childhood and often will have renal failure in early childhood. We will often consider a nephrectomy to prevent them from getting the renal cancer, the Wilms tumors. Fabry's disease, I've never seen it in clinical practice, but I have seen it on board exams. It's an X-linked deficiency of the alpha-galactosidase A. You get structural abnormalities and therefore functional abnormalities, not only in the kidney, but also in the heart and in the nervous system. Again, it's in boys more because it's an X-linked disease. For the boys who have it, as a pediatrician, mostly what I see is intermittent mild proteinuria, but these patients eventually will develop ESRD in their 40s. There is now an enzyme replacement for the kids with Fabry's disease, so whether or not they're going to still develop ESRD, the enzyme replacement hasn't been around long enough for us to know that, but there is now a therapy for it. Nail patella syndrome, again, this is another one of these conditions that I have not taken a board exam that did not include someone with nail patella syndrome. I don't know who writes these board questions, but they love nail patella syndrome. It's an autosomal dominant disease on chromosome 9. They present with microscopic hematuria and proteinuria, and then they have hypoplasia of their kneecaps, the patella, and dystrophic-looking nails. 10% of these patients do develop ESRD, so it's a real condition. Transplant is successful. Again, it's a genetic problem with something that's going on in the kidney. If you give them a kidney from someone else, it doesn't recur, so it's a disease that we can treat. Let's do one more section before we have our break. We're going to talk about cystic diseases and renal development. Polycystic kidney disease, autosomal recessive polycystic kidney disease is a disorder of the fibrocystin gene. It's not very common, 1 in 10,000 to maybe even as 1 in 40,000. It can present any time in childhood. These kids usually develop progressive CKD and often will require dialysis in their teen years, but not always. The cysts in autosomal recessive PKD are always in the collecting system, the collecting duct. So it's collecting duct cysts, and often they're so small you can't see them on renal ultrasound. I think I had so you have this picture in your syllabus as well. The kidneys often look big, so you see large kidneys, but you often don't see sort of standalone cysts. Hepatic fibrosis is universal in autosomal recessive polycystic kidney disease. So that's the thing to remember is that ARPKD presents with not only kidney cysts, but also liver fibrosis. Autosomal dominant polycystic kidney disease is much more common. Okay? In the old days, we used to think of autosomal recessive as the one that presented in childhood and autosomal dominant is the one that presented in adulthood. That's because it's asymptomatic in pediatrics, but with the advent of ultrasounds that are being done prenatally and postnatally, and every time you come into a doctor's office, you either get a CAT scan or an ultrasound or something, we are diagnosing autosomal dominant polycystic kidney disease in pediatrics more and more. That is the most common time of diagnosing ADPKD now. And as I said, it's 40 times more common than ARPKD. It's about 1 in 1,000 kids. It's more common in newborns than ARPKD. The kidneys are normal size, and unlike the ARPKD, where the cysts were located in the collecting ducts, in ADPKD, the cyst can be anywhere within the nephron segment. So you get cysts almost anywhere. They're macroscopic, and this is an ultrasound of the two different sides, and you see that they've got multiple cysts on each side of the kidneys. They have either no liver disease at all, or if they do, it's generally more mild. The thing that you need to remember for these patients on the board exam is that they present with Berry aneurysms, and there's a family history of those. And so if there's a family history of renal disease and autosomal dominant polycystic kidney disease is made, and there's no one in the family who's ever had a stroke, who's never had a hemorrhage, you probably don't need to screen that kid for Berry aneurysms. But if there has been a family history, those are kids who should be screened, because about 12% of them do have Berry aneurysms that will rupture later in life. Autosomal dominant polycystic kidney disease invariably progresses to ESRD. It's only about 5% of the glomeruli that are affected, but these cysts will sort of relentlessly and slowly grow. And although it's only 5% of the kidneys that have them, they keep growing and growing and growing, and they push out the normal kidney. And by the time people are in their 40s, or at the latest usually in their 50s, they need to be on dialysis for their autosomal dominant polycystic kidney disease. We use an ultrasound or a CAT scan to diagnose this. There are changing rules about how many cysts you need at what age to make the diagnosis. Again, I don't think that you'll be asked that on your board exam. Again, it's changing, because in the old days we used to use ultrasound, and say what you will about ultrasound, the lesions need to be bigger in order to see them. And so lesions that don't show up on an ultrasound are now showing up on a CAT scan. And so it's a more sensitive test looking for cysts, so we were able to make the diagnosis earlier. An MRA, again, for the cerebral aneurysms, if they're larger than 1 centimeter, you should clip them. You should have the neurosurgeons go in and take care of those for you. And then check the family history. If there's liver involvement, that's more common in ARPKD. ADPKD is, as I said, overall more common, and it is a pediatric disease. Nephronophthisis is a inherited glomerular disease. You get thickening and disintegration of your basement membrane. You get cyst formation, and over time, they develop fibrosis or scarring of their kidneys. It's an autosomal recessive condition. There are infantile types and adolescent types. The most common is what's called juvenile, or an MPH1 mutation. They have smaller than normal kidneys. You'll often see multiple corticomedullary cysts on renal ultrasound, usually in young school age. It's not a great disease. Most kids are ESRD by the time they're teenagers, so the median age for reaching ESRD is 13. The things that are clues to this on board exams, and again also in clinical practice, I'm trying not only to do a board review but also an intensive review of clinical practice. They have a lot of polyuria, so they lose the ability to concentrate their urine, so they pee a lot, and that's a common finding in nephronophthisis. The other thing is because of where the lesions occur, which is in the corticomedullary junction, that's the part of our kidney that makes erythropoietin, and so they get a normocytic anemia that is out of proportion to the level of renal failure that they have. With advanced renal failure, anybody will get anemic, but kids with nephronophthisis have a more pronounced anemia than you would think they would have at the level of kidney disease that they have. A couple of syndromes that go along with nephronophthisis. If they have nephronophthisis and retinitis pigmentosa, that's called senior Loken syndrome. And if they have cerebellar colobomas, that's Joubert syndrome. Again, I don't I think they've gotten away from those on the board exams where they'll tell you about a syndrome and ask you about the findings. But again, just so that you've heard of them, Senior-Loken and Joubert syndrome are part of those nephronophthisis. All right, medullary sponge kidney is an ectasia of the cortical ducts in the medulla. These patients present with stones, and they present with urinary tract infections. I honestly think that's all you need to remember about medullary sponge kidney is stones and urinary tract infections. They actually have a pretty good prognosis overall. There is a familial nature in this. We think, again, I put it in the hereditary section because we do think that this is an inherited condition. Renal ultrasound, what you see is an increase in echogenicity. Again, I'm not a radiologist, but just so that we get this clear, ultrasound is a sonar technique, right? We bounce sound waves into the body, and if they don't reach anything solid, those sound waves just keep going. And so liquid things on an ultrasound look black because the bounce never comes back. Solid things bounce the sound wave back, and so the most solid thing in our body is bone, and that looks white on an ultrasound. And so everything on an ultrasound looks anywhere between black, which is liquid, or bone, which is white. And we talk about the echogenicity of a kidney, which is how much is bouncing back. And normally what we do is we look at the echogenicity of the kidney and compare it to the structure that's right near it, which is the liver. The liver is a much more solid organ than the kidney. The kidney has a lot of blood vessels. It's mostly made up of blood vessels and fluid. Kidneys are all about, making urine and having fluid flow through there. And so the kidney should be less echogenic. It should be less bounce-backy, if I can say that, than the liver. And so when we talk about an increase in renal echogenicity, what we mean is that there's more solid stuff there. It's bouncing back more than normal. So inflammatory conditions will have an increased echogenicity. Renal parenchymal disease will have an increase in echogenicity. And when we talk about an increase in echogenicity, we're generally talking about compared to the liver echogenicity. All right, cystic dysplasia. There are a couple of clinical conditions that present that are cystic diseases where the kidney just never formed appropriately. One of them is Meckel-Gruber syndrome, where they have liver, eye, and polydactyly findings. The Lawrence-Moon-Bardet-Biedl syndrome, which is often just called the Bardet-Biedl syndrome. The kids are obese. They have retinitis pigmentosus, small genitalia, mental deficiencies, and polydactyly. And then finally, von Hippel-Lindau, which is another one of these conditions that presents with an increased risk of renal cancer. Von Hippel-Lindau is an autosomal dominant condition. About half to three-quarters of them will develop renal cell carcinoma during their lifetime. And unfortunately, it's not just renal carcinoma that patients with von Hippel-Lindau get. They get multiple cancers all over. They get CNS and angioblastomas. They get pancreatic and renal cysts. They get pheochromocytomas, so multiple neoplasias. All right, a 5-week-old boy presents to you with fussiness and occasional emesis. You palpate a 9-centimeter right flank mass, but the rest of his exam is normal. The most common cause of a flank mass in an infant is? And see, I just talked about kidney tumors. I was throwing you guys off. That's not true. It's actually reflux. And you might see this on your own. We'll talk about reflux later. But again, whenever we talk about renal masses, you're like, oh, they're really common. They're really not that common. The most common cause of a renal mass in a newborn is reflux. See, I tricked you there. And the reason that we talk about renal development is because it's been so long since we were in basic science and did embryology. No, that's not true. It's because if you understand the way that the kidney develops, it really does give you an idea of where in development these defects occurred, and a lot of the conditions that we're going to talk about will be a bit more clear. The mammalian kidney, the metanephros, develops from these transient precursors that we have, the pronephros and the mesonephros. The pronephros starts really early in development, 3 weeks of development is when you start the first kidney that you have. So the kidney that we have, this is not the kidney that you were born with. It's the kidney you were born with, but it's not the kidney you started with. That was your pronephros that started at 3 weeks. It doesn't function, but if you don't have a pronephros, you never develop a kidney. Next is your mesonephros, which takes place about a week later, and it actually functions, but only transiently, and then it regresses. Although in boys it doesn't completely regress because it becomes the vas deferens, the seminal vesicles, and part of our epididymis. Now the metanephros, which is our actual functioning kidney, starts at about the 5th week of gestation, and it starts from the metanephrogenic mesenchyme. It's this little bit of goo that sits out here, and that goo will secrete some chemicals that induces the mesonephric duct to form ureters. And so the adult kidney is actually made from 2 different embryological structures. The metanephros is made from it makes the nephrons and the interstitial cells, but the ureteric bud actually comes from a different part of the mesenchyme, and you've induced this growing out. And so the reason that I bring that up is because there are conditions in which there's a problem with the joining of the ureter to the kidney, and all of those come from the way that the kidney develops from one set of cells, the ureters grow into that and become the collecting ducts and ureter cells. And so we first start having kidney function at 9 weeks of gestation. We first start making urine about 3 weeks later, or 12 weeks of gestation, and nephrogenesis is complete somewhere around 32 or 34 weeks of gestation. The kidneys don't do a whole lot in utero because we have this wonderful organ that clears away our toxins called the placenta. After we're born, literally, we have to cut the cord and do this on our own, and so the kidney gets a significantly increase in blood flow from about 5% up to almost 15 to 20% in you or I. The transitional renal physiology that occurs right after we're born, there's a dramatic increase in GFR. Newborns are born with a GFR of around 10. So by classic or U.S. definitions, every newborn is born with ESRD, GFR less than 15, but it will rapidly increase. There's a drop in the initial high levels of renin and aldo, and then finally increased urinary concentrating ability. Newborns can only concentrate their urine to about 400 or 500. This is maybe 600 milliosms. You and I and kids over the age of around a year can concentrate up to about 1,200 milliosms. There have been over 30 genes that have been linked to renal malformations that lead to anything from bilateral renal agenesis, which is generally a lethal condition, to unilateral renal agenesis, hypoplasia, dysplasia syndromes we've talked about, multicystic renal dysplasias, nephronophthisis, medullary sponge kidney. Renal agenesis, as the name implies, is an absence of renal development. It might be genetic. There are also some acquired causes, insults that happen during pregnancy that can cause the kidney to never develop. It's typically a first trimester abnormality. Again, the reason we went through when all this happens is so that you know when the insult occurs. Bilateral, if you have bilateral renal agenesis, again, this is generally lethal because you have severe oligohydramnios. You're not making any urine in utero. You don't get to swallow or breathe in that urine, and believe it or not, urine helps the lungs develop. And so if you don't make urine in utero, you don't develop lungs. You get lung hypoplasia. Also, there's not enough room because without urine, everything is squished down, so you get limb abnormalities. It's called Potter syndrome. Unilateral renal agenesis, clinical outcomes really depend not on the kidney that's gone, but on the kidney that's left. And if you have a normal kidney on the other side, they generally do relatively well. Renal hypoplasia or dysplasia, varying degrees of severity. The renal unit does have some function in dysplasia, so it does make urine. It does have some GFR to it. Usually the kidneys at birth are normal, or they may be a little bit small-sized. The renal ultrasound, as I mentioned, will show an increase in echogenicity in a dysplastic kidney. And there is a family history to this. About 5% have family histories. The reason that I bring these up is because with renal dysplasia, you are born with a small kidney. The problem is that you're also born small. That's not a problem. It's actually fine because when you're small, the small kidney is able to do enough. But as you grow, dysplastic kidneys often don't grow. And so a kid who's born with a creatinine of maybe 1 or 0.8, it may be okay, but as the kid grows, the kidney doesn't grow, and they'll outgrow their kidney function. I actually have to go back to Houston this afternoon. I'm on call tomorrow. We were admitting a child. He's 4 years old, and he had dysplasia. He's getting his transplant on Monday. And he's been on dialysis for a while. Multicystic dysplastic kidney is a specific type of dysplasia where the kidney has no function at all. It can be unilateral or bilateral. Again, bilateral is generally lethal because they don't have any functioning kidneys. It's typically an acquired condition. They're born with it. What I mean acquired is it's not genetic. It's some insult that happens during gestation, either an obstruction or something that goes on that prevents the kidney from developing normally. You often get larger than normal kidneys. They look full term, and they have multiple cysts in them. And I show an ultrasound picture here, and then if you're looking at your syllabus, you actually see the gross picture here where they have these multiple cysts in their kidney. This is somewhat of a historic image because historically when we found a multicystic dysplastic kidney, we would do a renal ultrasound. We would see that it's multicystic. We would suspect multicystic dysplastic. We would do a renal scan. The renal scan would show no function on that side, and that's the tip-off of multicystic dysplasia versus one of the other forms of cystic dysplasia, is that they have no function. And since they didn't have any function, we would do this to them. We would have the urologist go in and take them out. And I say that that's historical because these days we generally don't take out multicystic dysplastic kidneys. We leave them in. The only reason to take them out these days is if they cause multiple infections or if they're causing hypertension that's difficult to control. Then we'll go in and take them out. What we need to worry about with multicystic dysplasia, most of these kidneys will resorb on their own, or they'll involute and shrink down into nothingness. What we need to worry about is the contralateral side, because just like kids with unilateral renal agenesis, these kids functionally only have one kidney, and about 30% of them will have reflux, not only into the multicystic kidney, but onto the other side as well. And if you have reflux into a single kidney, that's obviously more problematic. Medullary cystic kidney disease is an autosomal dominant condition. MCKD1, we don't know what the protein is, but multicystic kidney disease 2, we know makes uromodulin, which is a TAM-Horsfall protein. The kids present with hematuria, they present with stones, and they get, again, chronic kidney disease in adulthood. There are not any extrarenal abnormalities like some of the other cystic kidney disease. These are specifically kidney-related disorders, and their kidneys are normal size. So unlike ARPKD and ADPKD, where the kidneys are big, these are normal-sized kidneys. All right, in a child with Potter syndrome, so oligohydramnios, pulmonary hypoplasia, and limb abnormalities, the likely time for the renal insult is? Yeah, so 3/4 of you remembered that first trimester, early on in the pregnancy. That's when the kidney is first starting to develop. I noticed that you guys do much better on the questions when I ask them after I've discussed the topic than when I put them at the beginning before I discuss, because that's a theme that we have to work on. A 2-year-old infant is noted to have bilateral flank masses, and a cyst is noted in one of the 2 normal-sized kidneys. The blood pressure while sleeping is mildly elevated, and a positive family history of renal disease with a grandfather on dialysis. The most common type of renal condition is? Yeah, autosomal dominant polykystic. So even though autosomal recessive is the one that we think about as being the pediatric disease, in this kid, autosomal dominant is much more common. We're going to talk about tubular physiology, get back to some of those renal tubular acidosis. We'll start with a case. 6-month-old boy presents for a well child check. His appetite is poor. His weight is below the 3rd percentile. No fever, vomiting, diarrhea, or other problems. Lab studies are as shown here. Normal renal function, but a bicarb of 16. Urine-specific gravity 10-15. Urine pH of 7 with a negative dipstick. They're consistent with metabolic acidosis due to Yeah, so distal RTA. For that degree of acidosis, you would expect the urine pH to be lower than 7. He's not able to acidify his urine. Now, if someone asks you about what segment of the kidney does X occur, by and large, if you know absolutely nothing, you should guess the proximal tubule because that's where most of everything occurs. 2/3 to 3/4 of the water reabsorption happens in the proximal tubule. 2/3 to 3/4 of the sodium reabsorption happens in the proximal tubule. 2/3 to 3/4 of the potassium reabsorption happens in the proximal tubule. 100% of your glucose and amino acids get reabsorbed in the proximal tubule, and usually 100% of your bicarbonate gets reabsorbed back in your proximal tubule, and also 60 to 80% of your calcium and phosphorus. So if you don't know anything, proximal tubule is a good guess of where reabsorption occurs. In the thin loop of Henle, and I didn't draw the nephron here, but try to remember in your head, you've got the glomerulus and you've got the proximal tubule. In the loop of Henle, you're reabsorbing sodium. It's actively pumped out through the NKCC pump. In the ascending limb, you're reabsorbing potassium. And then in the distal tubule, you've got about 10 to 20% of your water reabsorbed. Remember, that's where your thiazide diuretics work. Sodium is reabsorbed via aldosterone activity. And then in your collecting duct, 1 to 2% of the water, again, that's an ADH mediated step, and about 5% of your phosphorus is down in the collecting duct. The reason that I point these out is because they are important when we talk about the renal tubular acidoses. 100% of your bicarb is normally reabsorbed in the proximal convoluted tubule, and in the distal tubule, you have acid secretion via the HK potassium exchanger, the hydrogen potassium exchanger and the hydrogen sodium exchanger, and that's done via an aldosterone mechanism. And so we introduced it when we talked about acidoses, but when we talk about specific renal tubular acidoses, the proximal tubule is where we're reabsorbing our bicarb, and the distal tubule is where we are excreting those hydrogen ions. This is a repeat. It's not exactly a repeat of the slide that we showed earlier, but it's close. The distal defect is one in acidification. And so what you are presented with is someone who's unable to excrete their titratable acids. Generally, we eat acid each day. Those of us who are meat eaters, we eat protein, and protein are made up of small amino acids, and it's our kidney's job to excrete those acids to keep us in a neutral balance. And so distally, all we have to do is get rid of the acid that we're eating in. And so the pH of a rabbit's urine, it's about 8.5 or 9. They don't eat any protein. They don't have to get rid of acid. We do because we eat acidic foods. And so treating a distal RTA, all you have to do is to give enough bicarbonate to replace the amount of acid that we're eating, which for most of us is, what, a gram per kilo per day or something like that for protein intake. Proximally, the kidney is responsible for reabsorption